To continue with the hernia, today we discuss about the management of hernia. In the last lecture, we talked about the relevant anatomy and pathophysiology of the hernia. And if any patient presents with the swelling over the inguinal area or any other part of the body, we start with the detailed history. Onset of the swelling, any aggravating or relieving factor of the swelling, and then go for the examination. And examination is the most important part in any hernia, because it leads us to the diagnosis. Diagnosis of hernia is made by the examination. We do not need any investigation for it. Patients are usually examined in the standing position and in lying down position, because if it is a small hernia, it may not be appreciable in lying down position. And if it is not appreciable, then we can ask the patient to cough or perform some Valsalva maneuver, so that it becomes apparent. And if patient presents with the swelling over inguinal area, examine it for the reducibility, cough impulse, tenderness over the swelling, any skin changes, or contralateral site for any concurrent other hernias, and content of the scrotum. Like the picture shows a left inguinal hernia. What are the differential diagnosis for the hernia? Because any swelling over the inguinal area is not inguinal hernia by its own. There may be other causes for the swelling over the inguinal area, like testicular swellings, more common are hydrocele, varicocele, epididymitis, torsion testis, any ectopic testis lying into the inguinal canal, or undescended testis. Other swellings may be malignancies like retroperitoneal sarcomas, secondaries to the inguinal lymph nodes, testicular tumor, lymphomas, or it may be simple cutaneous swellings like lipoma, sebaceous cyst, or swellings arising from the vessels, femoral aneurysm, or it may be a venous disorder like saphenous. Saphenous is the varicosities of the superficial veins in that area. So, these are the common differential diagnosis for the inguinal swelling. So, any inguinal swelling does not mean it is inguinal hernia, it may be something else also. So, we have to rule out all these swelling by the examination. They have different features like varicocele. Varicocele is a swelling because of the dilated pampiniform plexus, and these swellings will be compressible but not reducible, because it is a vascular swelling and it gives a feeling of the bag of worms, and there will be no cough impulse. And the same way the hydrocele is a scrotal swelling primarily, it may reach up to the inguinal canal, but primarily it is a scrotal swelling, and we will be able to palpate the upper edge of the swelling. So, if the upper part of the swelling is reachable, then it is more likely to be hydrocele than inguinal hernia, because inguinal hernia originates from the peritoneal cavity. So, we are not able to reach the upper edge of the swelling. So, all other points, they have different characteristic features. So, by examination we can easily differentiate between them. As I told, inguinal hernia diagnosis is clinical. We do not need any investigation to make the diagnosis of inguinal hernia, but if patient is obese or swelling is not very apparent, patient is presenting with the pain in the inguinal area, then we are suspecting inguinal hernia and we can go for some investigations. The most common investigation is ultrasound done in standing position, and it has a sensitivity of around 86%. So, it is a simple investigation done to identify any hernia sac that is not appreciable clinically. Other investigations may be if a patient still presents with the symptoms, but ultrasound does not detect any hernial sac, we can go for the MRI, because MRI detects the soft tissues abnormalities very well, and there are maybe other orthopedic causes for the pain in the inguinal area. So, those can be diagnosed by the MRI. A plain X-ray can show the, if it is complicated hernia or uncomplicated, it can show the air below the pubic symphysis. This air below the pubic symphysis, it is because of the bowel loop that is in the hernia sac. So, if the content is bowel, not the omentum, then we can find a air below the pubic symphysis on a plain X-ray that includes the pelvis, and this X-ray also shows the dilated bowel loops. It means this hernia is complicated hernia that has led to the obstruction. So, patient might have presented with the vomiting, pain, abdomen and distension, and X-ray shows a presence of inguinal hernia also. Before these investigations were available, when the CT was not available so easily or MRI was not available, then another investigation that were being done was herniogram. Herniogram means we instill some contrast within the peritoneal cavity, and it will, because of the gravity, it will go to the pelvis, and if some hernia sac is there, it will go within the hernia sac. So, this investigation is called herniogram. It shows the contrast material within the peritoneal cavity as well as into the hernia sac. And the image on the other side shows the CT scan cross sectional image that shows presence of the bowel loop within the scrotal sac. So, if the bowel loops are seen within the scrotal sac, it means they have descended into the scrotum, that is a hernia. We do not need CT scan to diagnose hernia. Clinical examination or most of the time ultrasound is sufficient enough. So, remember that hernia diagnosis is made by clinical examination. We do not need these investigations, but sometimes we may need it. Like in the last lecture, we discussed about the common pathophysiology of the hernia. So, these are the common management principles of the hernia. So, these 4 points are done in any hernia repair. First, we have to reduce the hernia content into this peritoneal cavity. Whatever the structure has protruded into the sac, it must be reduced within the cavity. Then, if the sac is large enough, then we excise the sac and close the sac. And the fourth one is the reinforcement of the abdominal wall, so that it does not recur. So, first we have to dissect and reduce the content, excise the sac and close the neck of the hernia and strengthen the posterior wall. So, these are the 4 steps done to repair the hernia. So, there may be different ways of doing them, but the principle remains the same. Few things about the prosthetic mesh that we use in repair of the hernia. Most of the time you will be hearing about the mesh is being used, but what is this mesh and what types are it, what it does. Mesh is a prosthetic material that is either in the form of a sheet or a net. A mesh is used to bridge the defect, to plug the defect or to augment a repair. Bridge the defect means there is a defect and we place a mesh over it without closing it, or we make a plug of it and push within the defect, that is plugging the defect. And third is, first we suture the defect, close it, and then we place a mesh over it to augment it. So, this mesh can be used in these three fashions. These mesh they can lead to the pain after the surgery. If a bowel adheres to it, they can lead to the fistula formation, or they may erode into the other nearby organs, or they migrate from their site. So, these are the complications of the mesh. As I said, the most of the time we use the mesh that is in the form of net, and there are pores within the mesh, and the fibrous tissue collagen they grow within the mesh. So, the mesh is incorporated into the tissues, it is not simply lying over it, but the collagen fibers grow within those micropores. There are two types of the mesh, synthetic mesh and biological mesh. Synthetic mesh is made of polypropylene, that is monofilament, or polyester, it is a braided filament, and PTFE. PTFE is a flat sheet. PTFE, most of the vascular grafts are made by the PTFE, it has a different characteristic. It does not lead to the clot formation, it does not lead to the adherence of the other organs, but these polypropylene it leads to the adherence of the other organs. So, if you put into the peritoneal cavity, the small bowel will adhere to it, but if you put PTFE graft, PTFE mesh, the small bowel will not adhere to it. So, the PTFE is costly, but it has better property and it prevents the complications. But because we place it within the peritoneal wall, it does not come in contact with the small bowel. So, most of the time we use polypropylene only. So, this is one type of synthetic mesh, and these meshes are classified based on the weight. We call lightweight or heavyweight. If it is density is less than 40 gram per meter square, it is lightweight, or if it is more than 80, then it is heavyweight meshes. But heavyweight meshes are lead to more contraction and stiffening, more complications. And mesh shrinkage, something is called mesh shrinkage. It is because the any wound that heals, and the final phase of the healing leads to the contraction of the wound. So, any wound heals by contraction. So, these mesh when we place, it has micropores, the collagen fibers grows within those micropores, and when it heals it contracts. So, the mesh will decrease in size. If you place that is called mesh shrinkage, and the reduction in size can be anything from 20 to 40, 50%. So, if we place a 5 centimeter size of the mesh, after contraction it may remain about, if we place 10 centimeter after contraction it may remain 6 centimeter. So, there may be there is a decrease of this size, and that is why we place this mesh should be placed larger size. We place 5 centimeter large enough to cover the 5 centimeter area around the defect site. So, that even after reduction it at least covers the defect. So, we use larger size of the mesh only to compensate the shrinkage. The other type of mesh is biological mesh. Biological mesh is made from the dermis, human or animal, pericardium, bovine pericardium and intestinal submucosa. So, these are biological meshes, but they are very costly and they can be used when these synthetic meshes cannot be used. The problem with the synthetic meshes are that synthetic meshes they remain in the body forever, they are not absorbed, and if there is any nidus of infection, then we cannot use synthetic meshes, because it will lead to the persistent infection. We cannot treat an infection in presence of a prosthesis. So, if the area is infected or very large, we cannot use this synthetic meshes, then we can go for the biological meshes. The problem with the biological meshes are that they are very costly. They provide a scaffold and to grow the new collagen fibers, and they will be absorbed after some time. So, they will not persist in the body forever, but they will provide a scaffold to growth of the new collagen fibers. So, as I said, any mesh except the biological cannot be placed in a presence of infection. So, these polypropylene meshes are non-absorbable, they will be there, but there are absorbable synthetic meshes also, like made of the vicryl. This is a polyglycolic acid fiber. So, vicryl sutures are absorbable sutures. We can use the same material to make a mesh, but again they cannot be used if there is a infection, because it will take around 3 months to absorb. So, if there is a infection, either we do not use any mesh or we use biological mesh. And if we are placing the mesh within the peritoneal cavity, like to repair an incisional hernia, there are various fashion of placing the mesh. One of the is the placing the mesh within the peritoneal cavity. Then we cannot use those polypropylene mesh, because the small bowel will get adhered to it and will lead to the fistula formation. So, we use the mesh that does not lead to the adhesion with the bowel. So, one is the PTFE mesh, other is the dual mesh. Dual mesh means it has two surfaces, one that has polypropylene and it adheres to the parietal wall, other is non-adherent surface that faces the small bowel. So, that is much cheaper, but it has two surfaces and should be placed carefully. So, to place a mesh within the peritoneal cavity, either we use the dual mesh or go for a PTFE mesh. So, these were something about the mesh. Remember, there are two kinds, biological and synthetic we cannot place in the presence of infection. So, now what is the treatment for inguinal hernia? If you have made the diagnosis of inguinal hernia, if patient is symptomatic, we treat that hernia, and if patient is asymptomatic, just some swelling over there, but there is no pain or patient, it does not affect the daily activity of the patient, then still we treat the hernia, but in some selected patients we can go for non-operative watchful waiting, like patient is very high risk, and if it is patient lives with near to the some hospital facility, where if there is some complication occurs, patient can visit the hospital immediately, then we can go for watchful waiting. Otherwise, the treatment of any inguinal hernia is surgical repair, whether it is symptomatic or asymptomatic. So, what's the, and it is surgery, there is no medical management for inguinal hernia. What surgeries we are doing? These are the surgeries for the inguinal hernia. There are three surgeries. These are three surgeries: herniotomy, herniorrhaphy and hernioplasty. Herniotomy means we simply resect the sac and close it. So, it is done in children with congenital inguinal hernia. So, remember that herniotomy is only for the congenital inguinal hernias. In adults, herniotomy is not a surgery to be performed. Herniorrhaphy. Herniorrhaphy is the surgery where we use the local tissues to repair the hernia, and it is only done when we cannot place a prosthesis mesh, because it leads to the high recurrent rate. So, herniorrhaphy is not a preferred surgery because of the high recurrence. Hernioplasty, plasty word is used when you are placing some mesh or some prosthesis. So, hernioplasty is the preferred treatment. We do this hernioplasty in nearly all the patients, and only when we cannot place the mesh because of an emergency surgery, we go for the herniorrhaphy. These are the open surgeries. Other are laparoscopic procedures, like again the principle is the same. It is the fashion where we do place the mesh differs. So, laparoscopic can be done by TEP or TAPP, total extraperitoneal or transabdominal, we discuss in detail. To perform the hernia repair, before we do this, we just revise the previous few slides from the previous lecture. You must be remembering the anatomy that we discussed last time. So, this is the anatomy that we discussed last time. This is the sagittal section of a parietal wall through the inguinal area. This is the external oblique. The external oblique, it is coming in front, folding inward to make the inguinal ligament, and this is the internal oblique, transversus abdominis. They are lying above the, making the roof of the, and behind it this yellow line is the fascia transversalis, and there is thickening of the fascia transversalis that leads to the iliopubic tract, and this is the preperitoneal fat, and this is the peritoneal cavity. So, this is the spermatic cord, and hernia sac will be lying within it, okay, if it is indirect. So, to operate it, we have to first open it. So, we make an incision here over the external oblique, then it has a superior edge, it will be lower edge. We dissect out this sac, and then we do the surgical procedures, like in this way. This is another way, you open it and dissect it. So, we keep on referring to this anatomy again and again. So, we use a local or spinal anesthesia. Incision is about 2.5 centimeter above and parallel to the ligament of this inguinal ligament. External oblique aponeurosis is open, it is from the front, that was from the sagittal. So, this above is the external oblique, upper part, lower part, then we reach into the inguinal canal, and this is the spermatic cord. Then we have to dissect out this sac, this inguinal canal, and this is the internal oblique. Some fibers from the internal oblique, they give the origin of the cremasteric muscles. We dissect out those cremasteric muscles, then we isolate the spermatic cord, and if it is direct hernia, it will be away or medial towards the medial side from the deep ring. This is the deep ring, this is the site of the direct hernia, and if it is indirect hernia, it will be along the spermatic cord. So, we isolate the spermatic cord, we dissect the spermatic cord to find out the sac of indirect inguinal hernia. And there are few nerves around it, like iliohypogastric and ilioinguinal nerves are there. We identify and preserve them. Cord structures are dissected and isolated. Then those 4 principles again we apply them. Sac is identified and dissected of the cord, content of the sac is reduced and excess sac is excised, sac closed at the internal ring, and posterior wall strengthening is done. So, these are the 4 principles that is common to all the surgical procedures for the inguinal hernia. Okay. You have to open the inguinal canal, dissect the spermatic cord, identify the sac, open the sac, reduce the content, close the sac, and then do something to repair the inguinal, to strengthen the posterior wall. So, all the difference that occurs in various surgeries is the way we strengthen the posterior wall, rest is the same. So, first we discuss about the some tissue repairs. Bassini repair is a tissue repair. Here we, after exposing the inguinal floor, we do all these procedures first. Open the inguinal canal, identify dissect out the spermatic cord, identify the sac, open the sac, reduce the content, close the sac. Then after this we start doing this repair. Then expose the inguinal floor, transversalis fascia is incised, and a triple layer repair is then performed. How? We are going to go to this picture, because if you open the fascia transversalis here, then you see there are 3 things above. One is the fascia transversalis, other is the internal transversalis abdominis and internal oblique. All these 3 they are taken and they are close to the pulled and close suture to the inguinal ligament. We do not have any. Okay. So, the Bassini's repair is like this. This is the inguinal ligament and this is the internal oblique, this is the transversus abdominis and this is the fascia transversalis. So, this is fascia transversalis, transversus abdominis, internal oblique, fascia transversalis. What we do? We take all these 3 together. Okay. We take all these 3 together and suture it to the posterior wall. There is a defect here. So, we have to close this defect. How we do? We take all these 3 and suture it to the, it becomes like this. This is the external oblique, we have opened it here already. So, this is the external oblique inguinal ligament, this is the internal oblique comes and attaches it, this is the fascia, this transversus abdominis also attaches it, and fascia transversalis also attaches it. So, we suture all these three to the inguinal ligament, the reflected part of the inguinal ligament. So, this defect that was there, it has been closed by these tissues. So, this is Bassinis repair. Okay. It is not difficult to understand, these three, they are sutured to the reflected part, they are pulled down and sutured to the reflected part. Because they are pulled down, normally they are not that much long, we are pulling them down. So, they are under tension. So, that leads to the recurrence. If they are tension free, that will not lead to recurrence. So, the only thing that it is under tension, so it leads to the recurrence. So, this is Bassinis repair. It is much easier to understand if you remember this sagittal picture of the inguinal canal. The internal oblique, transversus abdominis and transversalis fascia are fixed to the reflected part of the inguinal ligament and periosteum medially with interrupted sutures. So, this is Bassinis repair and this is the picture, because this is the from the front may not be very well that easy to understand, but that sagittal picture is easier. So, in this proximal one, they are opening this. This is the fascia transversalis, they are opening it and they placing the sutures, this internal oblique, transversus abdominis, fascia transversalis to the inguinal ligament, this is the inguinal ligament. So, all three are closed to the inguinal ligament. So, the defect that was over the posterior wall, because the posterior wall is only made by the fascia transversalis, but now it is being made by all these three. So, it is strength, leads to the strength. So, now what is this soldis? It is the same as the Bassinis, but what the soldis has done, that was 3 layered repair, this is 4 layer repair. What he has done is that he opened the fascia transversalis, and opening the fascia transversalis, what he did, he pulled this lower part above. Okay. Now, at this layer there are 4 layers. One is the internal oblique, transversus abdominis and upper part of the fascia transversalis, lower part of the fascia transversalis. So, he first sutured this lower part to the upper part. So, the lower part of the fascia transversalis is sutured to the upper part. Now, we have 4 layers and all these 4 layers, they are stitched to the inguinal ligament, the reflector part. So, it becomes 4 layer repair. The fascia transversalis is opened and it overlap to each other, that is called double breasting. So, again it becomes like this. This is the inguinal canal, this is the internal oblique, transversus abdominis, and this is the fascia transversalis, one part, other part of the fascia transversalis. So, there are fascia transversalis, there are 2 parts of the fascia transversalis only. So, it becomes a 4 layer repair of Bassinis, this soldis, sorry. Bassinis is 3 layer and soldis is 4 layer. So, it is like opening the fascia transversalis and then it made 2. It was like this, opened it and they made it like this. So, it was double breasting of the fascia transversalis. So, in this you can see they are stitching this lower part of the fascia transversalis to the upper part, but not at the edge, but over the posterior surface. So, it will lead to the two flaps of the fascia transversalis, and rest is the same as the bassinis. So, these are the two tissue repairs, bassinis and sulcis, and it is not difficult to understand if you remember the anatomy. And remember, bassinis is the 3 layer, sulcis is the 4 layer, and the 4 layer is because we have made fascia transversalis into 2 layers. They both have, although less recurrence rate than the previous surgeries, but still very high, and it is the high recurrence rate in the sulcis and bassinis are because of the tension, because we are pulling those tissues downward, they are not that much lengthy. So, they remain in tension and lead to the recurrence. So, we want to do something that release the tension. So, we want to do a tension free repair, and the tension free repair is only done when we are placing some extra tissues over there. Okay. So, then we place this prosthesis mesh, and the more commonly performed procedure is Lichtenstein. There are other surgical procedures that uses the mesh, but the more often performed is the Lichtenstein. It is also called Lichtenstein tension free repair, because it releases the tension over the tissues. What surgeries are done, how it is done? It is the same thing. We open the inguinal canal, dissect out the spermatic cord, identify the sac, open the sac, reduce the content, close the sac. Then what we do here? We take a large size of the mesh, that is 7 by 15 centimeter. The size of the inguinal canal is 4 centimeter, but we place a 15 centimeter mesh, because the mesh will contract. So, we try to put a larger size of the mesh, and how it is placed? This is the inguinal canal, this is the internal oblique, transversus abdominis, and fascia transversalis, and this is external oblique. So, we take a mesh and place between the external oblique and internal oblique, and we stitch it with the reflected part of the inguinal ligament. So, the mesh again, because it is bridging the defect, so it will strengthen the posterior wall, and it is placed between the internal and external oblique muscles. So, here a mesh is placed between the external oblique, internal oblique, and it is brought down and stitched to the reflected part of the inguinal ligament. So, it will cover it will make a covering over the posterior wall and strengthen it. And we make a opening into it, so that this is how from the front it looks like once we have placed it. This is the lower part of the inguinal canal, this external oblique, this is the reflected part, we suture it to the reflected part and we place it over the between the internal oblique and external oblique, and we make a small opening, so that this inguinal this spermatic cord come out through. So, this becomes a new deep ring and it lies over there, and it has very low recurrence rate. So, this was all for today. So, this is the general principle of the inguinal hernia or any hernia management. Remember these 4 principles that will be utilized anywhere. It is the dissection of the sac, identifying the sac, opening it, reducing the content, closing the sac and strengthening. So, everything that differs between the surgeries is how we strengthen the posterior wall or abdominal wall, rest is the same. And there are 3 surgeries: herniatomy, herniorrhaphy and hernioplasty. Herniatomy is done for congenital inguinal hernias only in children. Hernioplasty is the surgery when you use prosthetic mesh, and it is the preferred surgery. And if we cannot do this surgery, only then we go for herniorrhaphy. Hernioplasty, the contraindication is presence of a mesh, infection. If there is infection, then we cannot place a prosthesis. Then we have to go for the herniorrhaphy. Herniorrhaphy is to Bassinis and Solis. There are many other, but these are the 2 more common. And how they differ, one is 3 layer, other is 4 layer, and the prosthetic repair that is done more commonly is the Lichtenstein, and the mesh is placed between the internal and external oblique. At least remember these few things from today's lecture. In next lecture we discuss about the laparoscopic procedures and other procedures that are done for the open hernia repair, inguinal hernia repair. Okay. So, this was all for today. If you have any doubt, you can ask, otherwise we go for the attendance.